Dear colleagues, dear friends, it's a pleasure to welcome you for this new webinar organized by the school-based section. We will be dedicated to the posterior petrosectomy, a quite very interesting topic. Now all the speakers are not yet connected, so maybe we will wait a few minutes. And I hope that Sébastien Fröhlich and Stéphane Liber will connect very soon. Pierre Croche is already with us. And in the meantime, we give you also the opportunity to connect. All the participants will join you within a few minutes. So I will start the webinar in 5 minutes.
Stefan is here, so I believe we can start.
Hello, everyone.
Hello, Stefan.
I'm very sorry. I was on time, but my Zoom just asked me to update, so I couldn't log in. I'm very sorry. I hope we're running a bit late now.
It can happen. So, as I was explaining, this webinar is dedicated to the posterior petrosectomy, a very interesting topic, a difficult topic, not used by all surgeons, not practiced only by neurosurgeons. Most of the time, the ENT help us. A few neurosurgeons make the approach themselves, Pierre and Sébastien, I know. It gives you a different angle attack to some skull-based tumor, and those will be detailed during this webinar. But as usually, we will start with you, Stéphane, to detail the anatomy of this region. So please, the floor is up to you. Can you share your screen? It works.
Yeah, just a moment. Everything changed today because I had this update. It's a bit. After 2 years of using Zoom, it's still an experience. I'm sorry.
We see a message explaining that you start to share your screen, but your screen is not visible. Not your presentation. We see your desktop and.
Anything now?
All your slides are, yes, perfect.
Yeah, all right.
Yeah, great.
So thank you very much for this repeated invitation. I'm very sorry about the delay and the technical issues. I have to make up some time. So it's always a great pleasure and an honor to put some slides together to present some basic anatomy. This is not the surgical view. It's not talking about indications, variations, the technical aspects. It's just meant as a primer, as in previous sessions, to give some basic anatomy and some perspective, and also, as you can do in anatomy, obviously changing some of the perspectives and combining some of the perspectives, which is explaining why these technically demanding and also invasive approaches still exist, and which benefits they bring to the table. So I will be talking about some of the petrous bone anatomy. Some of the indications will certainly be covered in the 2 later talks. So we're discussing today the posterior petrosectomy, or the pre-sigmoid extension of a trans-petrous approach, which brings an additional perspective and additional trajectory to the skull base, especially to the ventral aspect of the posterior fossa, also the suprasellar aspect can be reached, and essentially it adds trajectories to the posterior, more traditional routes, as for example the retrosig approach. We discussed in previous seminars the anterior petrosectomy to this area, the upper part of the retroclival cisternal space, which is this subtemporal approach. We discussed the retrosig approach already in previous seminars, and now we have a dedicated session on the posterior petrosectomy, which is, as the name says, a pre-sigmoid trans-petrous approach, which has various extensions from just bone drilling, disconnecting the sigmoid sinus and exposing, essentially disconnecting and mobilizing the pre-sigmoid dura from the sinus, which already creates a lot of space, to various degrees of drilling of the intrapetrous structures as the semicircular canals, and depending on function and extent of previous functional deficit, also the cochlea or other structures. We covered a lot of bone anatomy in previous sessions. I will not go into this in detail. We have obviously the anatomy, the intrapetrous anatomy, for which I'll have some slides prepared. We have the retrosig, sigmoid sinus junction, the jugular foramen, the superior petrous ridge with the sulcus of the superior petrosal sinus, which is an important structure in this anatomy. In this approach, we have the asterion and all the structures within the petrous bone that are partially exposed in this approach. There's no reasonable way to cover temporal bone and petrous bone anatomy fully in just a few minutes. So I will skip this largely and have decided just to put some basic anatomy and CT scans together to depict some of the intrapetrous structures that make part of this approach. There's, however, one bony picture I want to show. This is an interesting picture which shows you the bony landmarks and also partly the trajectories that you have in all the approaches we already discussed, and the posterior petrosectomy approach, which is part of this webinar today. So we have on the right side of this skull model the petrous apex, which is the trajectory which would get you to the petrous apex and precysternal retrocellar cysternal space by the anterior petrosectomy. You have on the other side the asterion, the landmark for one of the landmarks for the retrosig approach, which is can be seen here in the junction of the sigmoid and transverse sinus, which is this posterior fossa approach. And you have on the other side the pre-sigmoid bone of the petrous bone, which is part of the pre-sigmoid approach we're discussing today. So these three approaches and their trajectories can be seen in this picture. Just briefly, some anatomy. We've discussed this in a previous session on anterior petrosectomy. Some of the intrapetrous structures in this on this right side, partially exposed of the posterior fossa and the middle fossa. So you have the trigeminal ganglion, the superior petrosal sinus here, the suprameatal tubercle down here, hypoglossal canal and jugular foramen structures, the porus jejemerinus, sixth nerve, fourth nerve, and third nerve here. So this is the petrous apex here, middle fossa, retrosig, and we're discussing the intrapetrous structures which are hidden in this bone. And this is a partial exposure, which I discussed in the anterior petrosal approach. So we have, again, on the right side, the petrous carotid, the intrapetrous, the cochlea, anterior or anteromedially. You have the facial nerve, the eighth cranial nerve, the intermedius nerve running into the meatus. Then you have the three canals, which can be seen here, middle ear structures, genu of the facial nerve, GSBN. These are structures that are discussed today, and also the drilled volume of a posterior petrosectomy, descending mastoid portion of the facial nerve here. This is obviously a basic anatomy. This is I just put this together to show some of the structures in correlation to CT scanner, which is obviously an interesting or the most important structure exam to plan this approach, to do this approach, and to understand all the stable landmarks that are then found in surgery. So this is going from inferior to superior. We have the mastoid and the stylomastoid process. All this transfer here into the facial canal. We have the jugular bulb and foramen down here. Going up, we have the jugular foramen, mastoid portion, retrosigmoid emissary vein. Going further up, we have the facial nerve running up here in its mastoid portion, which becomes the tympanic portion here. We have the cochlea, we have the lateral semicircular canal, we have the posterior semicircular canal, and to its superior, we have the superior canal, which is pointing upwards and forms eventually the arcuate eminence in the roof of the petrous bone, just anterior to the tegmen tympani and the petrous planum. So just revising some of the structures going from inferior to superior, we have the cochlea. There's one slide missing, I'm sorry. So we have the cochlea anteriorly, tympanic portion of the facial nerve running anteriorly, intra middle ear ossicles. The genu of the facial nerve can be seen here. This is the anterior genu, the second genu of the facial nerve, correlating here in the microscopic picture. Cochlea is drilled in this picture, and the semicircular canals pointing laterally, superiorly, and posteriorly. This is a picture of a retrosigmoid approach. We have the problem in this approach that essentially always cranial nerves have to be crossed in order to access the prepontine, more medial aspect, and also the area behind the sella, the cisternal space, suprasellar and infrachiasmatic cisternal space. And the idea of the presigmoid exposure is to turn the trajectory more laterally, and to add different angles and trajectories to this approach. This is again a retrosigmoid perspective, looking more laterally. This is olive, 12th nerve, 9th, 10th, 11th, foramen of Luschke here, 5th and 7th and 8th nerve. And you see, you always have to transgress these fragile nerves in order to get access to the prepontine area. So the presigmoid lateral extension is just turning this retrosig posterior, purely posterior fossa approach into a more lateral perspective. And in order to do this, we'll be hearing this by two experts in later talks. You have to essentially skeletonize the sigmoid sinus down to the jugular bulb. You have to disconnect the sigmoid jugular, the junction between the superior petrosal sinus running on the petrous ridge when it emerges into the sigmoid transverse junction here on the sinus, and you have to preserve. This is essential for the temporal variant draining veins that enter the sinus. And the bony exposure is one part of the approach, but largely the advantage of this approach or the benefit of this approach is produced by mobilizing the sinus, not so much drilling the bony volume, but mobilizing and disconnecting the transverse sigmoid sinus junction from the superior petrosal sinus, which is adding to the bony volume, which can be gained, as I said before, in various degrees of drilling just bone, skeletonizing semicircular canals, facial nerve, other structures, or even sacrificing them if function is lost or if it's necessary for the surgical goal. This is a more focused view. So we have the facial nerve exposed. This is the facial nerve descending in its mastoid portion. We have the three semicircular canals exposed. And we have a more lateral view on this left side, just anterior to the ascending sigmoid sinus, which becomes lateral sinus here. You see the disconnected superior petrosal sinus on the other side, which gives you this more lateral corridor right to the anterior ventral face of the pons in this case, with fifth nerve, fourth nerve here. The tent is cut and disconnected, also third nerve, and the entire ventral aspect of the brainstem, pons medulla, even up to the interpendicular fossa and the cisternal space, suprasellar infrachiasmatic cisternal space. This is would be nice to achieve this in surgery. Obviously, this is not possible, but it shows you some of the potential trajectories that are added by this approach. by transposing, skeletonizing, and transposing the sinus posteriorly, drilling the bony volume of the petrous bone, and adding this trajectory to a very limited, or rather limited, more medial trajectory, as you would have it from the retrosigmoid approach, or from the approach of middle fossa subtemporal anterior petrosectomy, as we discussed in a previous webinar. Obviously, these approaches can be combined. I would think that Professor Fröhlich is presenting a case later on, and the entire point of these procedures, these approaches, and combining these is adding trajectory and making exposure more safe and effective in order to tackle some of these pathologies in this area. This is again the anatomical exposure of a petrous bone. You see the superior petrosal sinus here, which is running in the roof of the petrous sinus and forms roof of the porus trigeminus. You see the incisura here, third nerve and trochlear nerve, the fifth nerve traveling from the brachium towards the middle fossa. Seventh and eighth nerve exposed here with the genu of the facial nerve, with GSPN running anteriorly with the petrous carotid, the cochlea partly exposed, and the three semicircular canals, middle ear ossicles in this dissection. This is just a photo to demonstrate the superior extension. So looking up, which is a trajectory which can be gained also in this approach. So we have fifth nerve here with the ganglion. We have the fourth nerve running in the tent. We have the third nerve emerging from the interpeduncular fossa between the PCA and SCA branches, and the optic nerve. And this space, for example, we have the pituitary stalk, and this space, as for epidermoid cysts or petrocleidomeningioma or other craniopharyngioma, can be accessed and space gained by this exposure. This is essentially the same thing in a wider exposure, which shows you this ascending trajectory towards the intrachiasmatic space. Just briefly, because this is a technical part of this approach, is just briefly covering the superior petrosal sinus, as I said, which runs in the tent in the roof of the petrous ridge, which needs to be disconnected from the from the sigmoid lateral junction, so that the sigmoid and the jugulus, the sigmoid and transverse sinus can be mobilized posteriorly to open this trajectory between the inner ear structures and the posterior fossa. I will finish this brief introduction with this image, which essentially is the maximal anatomy. It would be nice to have this exposure possible in surgery. Again, retrosig trajectory here, the space working corridor of the presigmoid approach, some sort of transpetrous posterior petrosectomy, translab, whatever you want to call it, and to whatever extent resection of petrous bone structures is added, and of course the middle fossa anterior petrosectomy trajectory, which we discussed in a previous webinar. This was just meant as a brief intro to the two following talks. There's a lot of anatomy, obviously, for this. I wanted to do this just brief as a primer. And as always, thank all my mentors and teachers and friends in surgery and anatomy for all these data and all these insights. Thank you very much.
Thank you again, Stefan, for having shared with us this very complex anatomy. It was so nicely illustrated. Thank you, and it's a perfect introduction for the clinical and surgical aspect that will be detailed by first Pierre Hugues and then Sébastien Fröhlich. So, Pierre Hugues, it's up to you to discuss with us your way to
can you hear me? Yes,
make this approach. Yes, please, Pierre Hugues.
I'm going to share my screen. Can you see my screen, Michael?
Yes, but not in full mode.
Okay, let's do it. Um, it's coming soon, I hope. So, okay.
Yes, Bugs,
Fine.
please.
Okay, dear colleagues, thank you very much for inviting me again. You said, Mikhail, that of course this approach is not in the hands of the neurosurgeons, and I do agree with you, because all the otologists are able to do that, because this is just an extension of the mastoidectomy, and it's a pity that a lot of skull-based neurosurgeons do not manage this approach by themselves. I say that because when they are helped by ENT surgeons to do that, usually the otologist will make a regular approach, and mostly a kind of narrow approach. And as said Stefan, the key of this approach is to widen the angle between the sigmoid sinus and the superior petrosal sinus, in order to give a better corridor. If you do not know this anatomy by yourself, the otologist will give you the case with a almost done pre-sigmoid approach, and if you are not able to improve this approach, you will have the feeling that the approach is very narrow, which is wrong. This approach is large. So to move back quickly to the anatomy, because it was nicely done by of course, Stefan, you may see that the petrous bone is separates the middle fossa from the posterior fossa, and broadly speaking, the angle between both posterior surface of the petrous bone is around 100 degrees. Of course, all this bone is covered by dura, except the lower face of the petrous bone, and except of the base of the petrous bone, because the base of the petrous bone, which is a really very important structure, is the entry point. This is the entry corridor to perform all this posterior petrosectomy. So I invite you to understand the anatomy and the landmarks, particularly the tip of the mastoid, the asterior in the back, the posterior zygomatic point here, because if you are familiar with all these bony landmarks, which are very reliable, you will be able to shave that to enter and to start to enlarge mastoidectomy. Pay attention that if you reflect the soft tissues, you will, before entering at the level of the external auditory canal, you will find a kind of process which we call the Henle spike, and the Henle spike in your extreme point where you should stop reflecting the soft tissue. If you go over this point, you will probably violate the skin of the external auditory canal, which might, of course, hamper your surgery. So if you look at the lower part of the petrous bone, this is something we are not familiar with, but grossly speaking, we can say that we have two, I would say three different regions. You have the anterior one, which match with the lower part of the foramen lacerum. You have the middle part, which is the exit zone of the carotid canal and the jugular bulb here. And you see the close relationship between both exit zones of these vessels and the lower cranial nerves here and the hypoglossal canal there. And it might be interesting to know about this anatomy, particularly if you operate through infratemporal approach, fish approach, extreme lateral approach. And the posterior third of the lower part of the petrous bone is something which is very important, because it is marked by the stylomastoid foramen here, the big proeminence of the mastoid tip here, and medially to it the digastric groove where runs the digastric muscles. So see the connection between the styloid process here, the stylomastoid foramen here with the fascial nerve is coming there, and the digastric the mastoid point. If you look at the posterior part of the petrous bone, it is framed by the groove of the sigmoid sinus in the back, framed by the jugular foramen in the front, and the big groove of the inferior petrosal sinus. And you have at the top the petrous ridge here, and you observe this triangle shape posterior surface of the petrous bone. Of course, inside you have the big hole of the meatus here, but you have also a petromastoid foramen here, and this is the entry point of the subarcuate artery. And sometimes if you damage the subarcuate artery, you may expect some hearing deterioration of the patient. So this surface is more complex than expected. If you look at the roof of the petrous bone, the superior surface of the petrous bone, you have three parts again. The anterior part is marked by the depressions, and above it you have the Meckel's cave. If you drill this part, you will perform an anterior petrosectomy. You have the middle part here with just underneath the cochlea in the front, the retromeatal section in the back, and in between the roof of the internal auditory canal. And then you have the posterior third of the superior surface. If you drill it, you will find, of course, the mastoid air cells here and the posterior labyrinth, which is marked by the semicircular canal. Pay attention that laterally to this surface of the petrous bone, you will have the middle ear. Of course, otologists, they know that, but neurosurgeons must be familiar with that, because if you shave the tegmen tympani, this is the middle ear here, and at the front you have the eustachian tube here. At the middle, you have the head of the malleus and the uncus, which is here, and the uncus is not far with the posterior semicircular canal, and there is a close relationship in between because we have a small wall, which is called the fossa ancudis. And if coming from the back, you find this fossa ancudis and the horizontal part of the uncus, you are very close to the external semicircular canal. It's always difficult for neurosurgeon to shave the mastoid and to find the depth where you will enter at the vicinity of the external semicircular canal, the horizontal one. But if you have this landmark, the posterior portion of the uncus and the fossa ancudis, you cannot mistake. It means that you are at the level of the semicircular canal, and you have to stop, because you know that if you violate the semicircular canal, the patient will become deaf. Okay, so middle ear, it's a kind of jewel box. It's very important to know what's inside, because pre-sigmoid approach means that you will enter between the sigmoid sinus and this famous jewel box here. So important to know what's inside. Okay, Stefan said that you have to know about the complex anatomy of the three portions of the facial nerve. Of course, when doing the pre-sigmoid approach, the key is to understand the course of the third portion of the facial nerve here and the junction between the second portion and the third portion. And you can see on this upper panel here, the close relationship between which is, by the way, a coronal section of the bone window CT scan. You can see the close relationship between the middle here, the second portion of the facial nerve here, and the lateral semicircular canal. And the second portion is running just below the second portion, the lateral semicircular canal. Look here, this is the sagittal section of the bone window of the petrous bone here. You see the relationship between the lateral semicircular canal, the second portion, and here the third portion. Stylomastoid process is here, and you see here another canal, which is the chorda tympani here. Okay, looking at the cadaver dissection, you see again the relationship between the second portion, the third portion, stylomastoid process, stylomastoid foramen here, and the lateral or horizontal semicircular canal. And you see how the narrow can be, how the corridor can be narrow if you do not skeletonize the sinus. I will be back to this technical note later on. Okay, look at the variations. Stefan said that we had variation. I do agree. You have superficial variation of the course of the sinojugular structures, and you have deep one. The superficial variation is named contract mastoid. When the distance between the posterior canal, external canal, the posterior wall of the external canal, and the sigmoid sinus is less than 15 millimeters, you call that contract mastoid. And you see how much how you need to skeletonize the sinus and to drill and to push it backward if you want to widen this approach. Okay, so this is a contract mastoid. Here you see the jugular bulb position. You have here a close connection of the jugular bulb with the labyrinthine block. And this configuration is very frequent. And in around 20-25% of our patients, we find a relationship between the jugular bulb and the semicircular canal. If you do not know that, if you do not know how to manage the high jugular bulb, you will damage damage it. This paper, we published that 20 years ago. It was a technique to manage the high jugular bulb. It was quite complicated technique. Nowadays, perhaps I would do different. I would skeletonize and coagulate the dome a little bit more. But leaving a piece of a kind of eggshell technique, pushing it backward is challenging. This is something we can do, but you need to master the drilling technique, of course, very much. Okay. By the way, these variations are key. Here on the left upper panel, you see how much the pneumatization of the mastoidea cell are big. And you see that in this case, it will be quite easy to drill and to find and to expose the mastoid antron. Conversely, in this panel on the right here, you see how the mastoid is compact. You have only one cell remaining, which is the mastoid antron. And drilling this compact bone is really time-consuming and harmful. So it's demanding. So be aware that the information you get from the pre-op CT scan is key to facilitate or to hamper the drilling. And you have to be prepared to drill this kind or this kind. Okay, I would pay tribute to my previous mentor, Professor Pellet in Marseille, who conceptualized segmentation of the petrous bone. And he divided the petrous bone into 4 segments. And he said, well, we have a mastoid segment in the back, we have a labyrinthine segment medially, we have in the front a carotid segment, and we have here a tympanic segment. And dividing the petrous bone into these 4 segments will make you understand how much you have to remove to go from simple petrosectomy to complex one. And if we consider that the retrolab approach is the cornerstone, is a standard is the pillar of all the approach, you will understand that you have just to realize mastoidectomy to shave the bone from the mastoid here to achieve a pre-sigmoid approach. But if you want to move to the translab, you will have in the same time to resect the posterior segment and also the labyrinthine segment here, of course. And if you want to go to the transcochlear approach, which is an approach we do not do anymore today, you will have to shave the 3rd segment, which is a carotid segment. Okay, so this concept of segmentation of the petrous bone will help you to understand how much you have to remove. If you have to perform a combined petrosectomy, you will preserve the labyrinthine segment, and you will achieve a carotid segment resection plus posterior mastoidectomy. This is the combined petrosectomy, and I guess Professor Fröhlich will discuss about that. So going through the approach, this is a C-shaped skin incision around the external ear. You can do 1 layer, you can do 2 layers. Usually I do 1 single layer all the way to the periosteum, and then I originate the periosteum as far as I can meet the endless spike. If you meet the endless spike, you have to stop, because otherwise you will damage the external auditory canal. I'm now on the right side, and you can see I put it in the middle center panel here, the orientation of the semicircular canal. This is the view you will have on the right side. You are behind the patient and you are shaving gradually. And what you shave the temporal fossa here, you erase the bone here, and you skeletonize the sigmoid sinus here. Be aware that if you use cutting drills, you might damage the sinus because the sigmoid sinus is very fragile. So gradually you have to shift, don't make holes, shave gradually, step by step from the superficie to the depth in order to expose the angle between, and this is the key, in order to expose the angle between the temporal fossa and the sigmoid sinus. This sinodural angle is also called the Citelli angle, and you have to improve this angle to open the corridor. So you will find at one time, once you will find the here the mastoid antron. The mastoid antron is constant S cells, and if you find it, you will be able to mentalize, to identify. Of course, you can be helped by the navigation here, but the compact bone of the labyrinthine block. The bone here is this is kind of cancellous bone, except in the case of compact mastoid. But in the other case, you can see how much is compact, how much this bone is compact. And zooming on your patient, you will gradually skeletonize the semicircular canal here. Once again, think about the positions of the semicircular canal here to mentalize the position in the real life, and you will shave around the labyrinthine block here. Okay, look, this is the first step. I open the angle between the sigmoid sinus and the temporal bone. We are on the right side here. You elevate the dura from the temporal floor. You elevate the presigmoid dura from the posterior petrous bone, and you will follow in the back the petrous ridge here in order to widen the angle. Gradually, you will shave this cancellous bone here. You will be helped, if you want, by the navigation. You can even navigate your microscope. You can even navigate your drill. This was done here in this case. We navigate the drill, and gradually we will shave until you can find the compact bone of the semicircular canal. You see here, the first one you will find will be the posterior here. And be careful, because the posterior, if you see the blue line in the middle of the posterior, you have to stop immediately, because if you open the blue line, you will open the endolymphatic canal, of course, the endolymphatic fluid, and you will expect some death. Okay, here you see it's extremely important to shave. It's time consuming, I must admit, to shave around the semicircular canal. You will find the posterior, then you will find the external. Remember the relationship between the external with the second portion of the fascial nerve and the third portion here. Please look at this panel here, it's indicates. So you shave. Be careful that you have an important landmark at the junction between the posterior and the superior. This landmark is named the common crus, and you have to shave around the common crus in order to improve your angle of vision. Okay, so at the end, this is what you will have. You will have you achieve the skeletonization of the sinus of the canal here. Think about my uncus. I told you the uncus is there. This is a good landmark to find the lateral semicircular canal here. You see the relationship in between them. Second portion of the fascial nerve, third portion, chorda tympani, chordal recess in between both. You have here the posterior semicircular canal. By the way, at the middle length of the posterior semicircular canal, you have here the lymphatic sac, which is an important landmark here. Pay attention to the jugular bulb. Pay attention to the high jugular bulb here. You see, you have to drill in between the the floor of the temporal fossa and the presigmoid dura in order to open your CTLE angle. Okay, this is in real life. You see the upper panel here. Posterior semicircular canal, lateral semicircular canal, superior one, which is in the depth, common crus to skeletonize, to optimize here. You don't have to shave too much the third portion of the fascial nerve. You need to expose the presigmoid dura, okay? That's enough. Okay, the way you have to open the dura depends what you want to do. I like this M-shaped opening of the dura here, because I can put back the flap at the end of the surgery. But in some case, there is a need, and as said Stefan, there is a need to cut above and below the superior pectoral sinus, to cut the sinus, and you will achieve a transtentorial approach. And usually the presigmoid approach is also a transtentorial approach, but you have to skeletonize the superior pectoral sinus, CTLE angle here, to cut above and below the superior pectoral sinus, to cut the tentorium all the way to the free edge of the tentorium, of course. So, for example, clinical application here, this is what we did in the past. In the past, I usually use this approach to remove this big pre-sigmoid, retromeatal big meningioma. I must admit, I have to be honest, I do not use this approach anymore for this kind of tumors, because you can do the same job using the retrosig approach. Hopefully, Marcos Tatageba is not with us, but he will say it's a shame. Use my semi-sitting retro-sig approach. You will do excellent job. Okay, but if you want to achieve a Simpson 1 resection, including the dura and the bone, all the retrolab approach is the only one to perform a Simpson 1 approach in this case. And as I told you, if you keep the semicircumnal canal, you will preserve hearing, and it was the case here. This was another case operated recently. I found it a nice illustration of what you can do with a retrolab approach. This is a retrolab plus, because in this case, you see how much the dura of the tentorium was involved by the meningioma. And this approach, which is a transtentorial approach, allowed you to remove, of course, the posterior fossa compartment, but the part of the tumor which was above the tentorium. Or I said that Marcos would say that you can remove from behind and from below. This I do agree, but it is safer to do a pre-sigmoid retrolab approach in this case, of course, rather than a standard retrosig. This is my opinion, but we can discuss about that. So at the end, for the closure, I usually use the facts. I had putting some Duragen, some substitute. I usually harvest the fat from the abdomen, and I plug with fibrin glue, and you see it's achieved here. The petrous bone has been drilled in the back, and you see you plug it, and as long as you occlude all the air cells, you won't expect any CSF leak. So fat is really very safe to close. Okay, more confidential indications are this kind of very rare tumor. This one was what we call an endolymphatic sac tumors. You know that in the Van Impe-Lindo disease, they expect on both sides, and they are locally aggressive tumors. But this is really very nice to operate this tumor using a pre-sigmoid approach. It makes sense because the tumor develops from the endolymphatic sac and destroy the bone posteriorly to the labyrinth, and it's legitimate to use this approach to remove this. I have here another case, which was much more bigger in a young woman. You see how much the bone was destroyed here. And of course, in this case, it's legitimate to use a posterior petrosectomy. And probably in this case, you will have to make a translab approach much more than a retrolab approach. Okay. This indication is nowadays very confidential. Fistulas, particularly Borden 2 and 3 fistulas. In the past, before the era of the very innovative job of the endovascular people, we used to operate these fistulas, particularly the Borden 2 and 3, using this kind of a pre-sigmoid approach. Because with the pre-sig, you can disconnect all the dura, all the efferent arteries coming in the fistula at the level of the transverse and sigmoid sinus, and you can even plug, even sacrifice the sinus by itself, because usually the sinus is not effective anymore. Look at this big fistula. In case of failure of the embolization, you can always say to your endovascular neuroradiologist, okay, if you cannot achieve to put the glue or to occlude the sinus, I can do the job. But you can do the job only if you disconnect all the lumen of the sinus and the dura that covers the sinus. So it's a backup solution for the fistula, and I find it very, very convenient to use. Of course, I won't go through the details of the combined petrosectomy because Sebastian will do that, but you see, and this is one of my key message, the retrolab approach is the corridor, is the entry point of all the other ones. I told you the pre-sigmoid, the translab, the transcochlear, the combined approach, and this patient was operated using a combined approach. And you see in this lower panel here, the bone job that has been achieved. This is a conservative approach because you preserve all the autoneurological structures here. And this is very elegant, but Sebastian will go through the details. You can also use in very confidential indications, this is what we call the pre-sigmoid transjugular transcervical approach. And if you need to operate large glomus jugulare tumors, you first start with the pre-sigmoid, but you have to dissect the root of the sinus all the way to the cervical area. This was the case in this case. Okay, I will finish with key message. retrolab is the cornerstone of all the posterior petrosectomies. This is a conservative approach. The key is to widen the angle between the presigmoid sinus, the sinus, and the temporal fossa, CTD angle. The space you gain depends on anatomical variations and the ability to overcome. It's usually indicated for presigmoid tumors, particularly bony tumors. Nowadays, it's combined with other transpetrous tapes. Be careful, pay attention to the closure and to the perioperative management, I would say, as always. I thank you for attention.
Thank you so much, Pierre-Hugues. We had the chance to appreciate how you master this approach and the techniques. You detail many tips and tricks. Thank you so much. I expect that Sébastien will give a complementary talk to yours, and maybe we can discuss after your two talks some issues. So please, Sébastien, up to you.
Hello, everyone. Nice to see you. Let me share my screen. Yes. That's okay. You see it? No, not yet.
Good.
Hold on. Yes. It's okay.
All the slides are visible, and now it's okay. Perfect.
Now it's okay. Okay, so Pierre-Hugues has already said a lot of things about posterior petrosal on combine. So there may be some repetition. I think we share the same opinion that it's a neurosurgical approach, and I strongly believe that skull-based surgeon should be able to perform a posterior or combined petrosal approach. It's yes, ENT can help you for the mastoidectomy, definitely, but the mastoidectomy is the easy part of the approach. The more difficult part of the approach is how to manage the sinus, how to open the dura, how to do the anterior petrosectomy if you want to add an anterior petrosectomy to the posterior petrosal. So it's really something that neurosurgeons, skull-based surgeon, I think should be able to do on their own. So as we said before, posterior petrosal, combined petrosal, you follow the petrous bone, it's an arrow that bring you to the center of the skull base. So every time you have a lesion in the petroclival region, clivus, it's a nice way to get there without too much retraction. You drill some bone and you use this bone together with a different way to manage the dura on the sinus, transposition of the sinus, you create a space to reach those deep region. So posterior petrosal is really the main part of the combined petrosal. The combined petrosal is just an addition of an anterior petrosectomy to the posterior petrosal approach. The indication for me, it's petroclival lesion, mainly petroclival meningioma, not small one or mid-sized one. The one I treat with this approach, it's more large or giant ones. Otherwise, I use retrosig approach. I use it sometimes for some big chordoma, chondrosarcoma, especially chondrosarcoma when it's going quite laterally. Epidermoid cyst, the giant ones, you want to have multiple line of sight to resect the cyst and to give a chance to the patient of cure, which means to take the capsule of the cyst out, that you can only do during the first surgery. Extremely difficult to do it if it's already a recurrence because of the scar. Giant schwannoma sometimes, and I did few cases of craniopharyngioma, retroinfundibular one. So the approach we are talking about is not a retrolab approach. Retrolab approach is only a part of the posterior petrosal approach. Because you see that if you just do a retrolab approach, you don't manage the dura, you have a very narrow space, and this narrow space, in fact, lead you more to the petrous bone itself than to the subarachnoid cistern. The concept of posterior petrosal is really to work from down up, lateral to medial, on posterior to anterior below the temporal lobe. If you follow this concept, in fact, you don't need much temporal lobe retraction. But to be able to do that, the only way to have this line of sight is to transpose, to mobilize the sigmoid sinus and transverse sinus, because it's on your way. And this cartoon is an illustration of that. If you follow this red line of sight, you see that the sinus is really in front of you. If you want to be able to keep going below the temporal lobe, you have to mobilize the sigmoid sinus, transverse sinus to run below the temporal lobe towards the retroinfundibular area, petroclival region. So it's really a question of mobilizing the sinus. On most of the bony work we are doing, in fact, is to have a control to the dura anterior to the sinus, to have a control of the tent, to be able to do a dural opening in front of the sinus, to cut the tent, to be able to free the sinus and to push it backward. So it's, I like to compare frontotemporal approach on posterior petrosal because it's quite similar. On one side, you do a frontotemporal craniotomy. On the other side, you do a temporo-occipital craniotomy, this L-shaped craniotomy. On one side, you work between frontal lobe, temporal lobe, you open the sylvian fissure. Posterior petrosal, you work between temporal lobe and cerebellum. Frontotemporal, you drill the sphenoid ridge. Posterior petrosal, in fact, what you drill is the petrous ridge. You should focus on the petrous ridge. You work along the orbit on one side, you work along the labyrinth on the other side. And at the end of the approach, with a frontal temporal approach, if you want additional exposure, you can drill the anterior clinoid process. With a posterior petrosal, you can drill also the tip of the petrous ridge, which is the petrous apex, which is a combined petrosal. So if you look at those two images, it's very similar. On one side, you focus on sphenoid ridge. The other side, you focus on petrous ridge, work between frontal and temporal, work between temporal and cerebellum. But you see here that working between temporal and cerebellum, the thing that you need to do is to mobilize sigmoid sinus, transverse sinus. The posterior petrosal and combined petrosal, why I like it for petroclival meningioma, for example, because I have multiple line of sight. I can look at the tumor from different direction. I can look for the dissection of the sixth nerve, for example, I use the anterior petrosectomy corridor. If I want to look at the facial nerve, I can look infralab. If I want to look at the trigeminal nerve, I look from down up below the temporal lobe. For each cranial nerve, each complex relationship between the tumor and the structure like vessel or cranial nerve, I have an optimum line of sight to work on it. Retrosig, you have only one entry point. It's nice for a vast majority of tumors in this area, but for the large and giant one where it's tough to predict where will be the nerve, I prefer the combined petrosal. So transposition of the sinus, again, it's a question of how you open the dura to do that. And that's the result of the dura opening. I do first an opening on the temporal dura. You have to go far back above the transverse sinus to be able to push the transverse sinus down. You have to do an opening of the presic dura. And then you have to cut the superior petrosal sinus, either posteriorly, but you can also cut it anteriorly through the anterior petrosectomy like this. You keep sometimes the drainage of the superior petrosal veins, for example. And at the end, this is the exposure you have with the mobilization of the sinus, this very nice line of sight that run below the temporal lobe. If you do that, you don't need much retraction. Pre-op workup is extremely important. I will not go over this because you had a beautiful presentation from Pierre-Hugues. Looking at the variations, looking at the pneumatization. If it's pneumatized like this, the amount of work you have to do into the petrous bone is limited. You just need to open those air cells together, and you stop when you start to have white ivory bone because it's a critical structure behind semicircular canal and fallopian canal, which is more challenging than the semicircular canal to drill, but it's about the same. I just show you these pictures because it's a case I did yesterday. It's an interesting case because there was no pneumatization of the petrous bone or extremely limited pneumatization. You can still do it, and it shows you that the reason I wanted to use this approach is really to have an optimum line of sight to work on the tumor, even if it's not very favorable in terms of petrous bone anatomy. The only difference here is that instead of working in out like you would do it in the petrous bone with a strong pneumatization, here I worked out in, which means I peel the dura from the petrous bone and then I get into the petrous bone to find the structure. But it's about the same. Preoperative workup, MRI, extremely important to identify variation, how the tumor extend in different area, compartment, Meckel's cave, cavernous sinus. Venous drainage, especially on the left side, is something extremely important. It happened to me that I was not able to do the approach to cut the tent because I didn't saw before the surgery that there was a big draining vein of Labbe draining into the tentorium. So it's something you have to be extremely careful of, especially on the left side, where the vein of Labbe drain. If it's too anterior on the sigmoid sinus, you will not be able to transpose the sinus. This is a beautiful picture from Rotten. You see this vein of Labbe. If it stops here, it's painful. If it stops backward, well, it's much easier to mobilize. So the way I do it, but we changed the technique in the last 2 years, I would say. I'm not doing a C-shape incision now. I am doing a question mark incision starting along the mastoid, at the mastoid tip, but once the skin incision is done, it's about the same. Interfacial dissection to be able to retract the temporalis muscle anteriorly as much as possible. You need to expose the root of the zygoma. You elevate the nuchal muscle. This is a video to show the soft tissue work here. Detachment of the nuchal muscle from the mastoid, nothing special. Bone flap, you see on the previous video, it was the way I was doing it before. I was doing the mastoidectomy before and then the bone flap, and I changed. Now I'm doing the bone flap first. It's something you have to be careful of with the transverse sinus because bone flap on both sides of the transverse sinus. Sometimes I just do a big burr hole on the transverse sinus and then I do 2 bone flap. Depends on the age of the patient. In elderly patients, the dura is stuck to the bone, so you have to be more careful. It doesn't matter if you do 1 piece, 2 piece, 3 piece, you can reconstruct it easily at the end of surgery anyway. What is important is to keep the sinus intact. Why also I do this craniotomy first? Because I can do a cosmetic mastoidectomy, which means I keep the outer wall of the mastoid for reconstruction at the end. Patients are happy not to have a big hole behind the ear. So then it's a time for mastoidectomy. We had, again, a beautiful presentation before, so I will not go on the details of this. I start with a 5 mm cutting. Then when you have the cortical bone over the sinus, I take a big ball to unroof the sinus. And then to get into the mastoid, usually I start with a 4 cutting, 3 cutting, and once I have the labyrinth and I have envisioned the trajectory of the fascial, I start with a 4 or 3 course diamond, and I finish with a 3 mm diamond for the fascial nerve, for example. But it depends on the size of the mastoid. Sometimes you have very small mastoids, sometimes you have big mastoid, it depends. Important landmark to me, but I am not using it much anymore. But in the beginning, I was using the short arm of the incus to give me the direction of fascial below the lateral semicircular canal. With experience, I don't really need to this landmark anymore. I really rely on the lateral semicircular canal. Fascial is below. And then in the infralab corridor, you shave from back to front to identify the fascial nerve. You hold it like a pen and slowly you get to fascial. Monitoring is extremely important, obviously. Be careful with some variation of the trajectory of fascial. Sometimes it's making a little S. So on the upper aspect, it's more close to the posterior fossa dura. You need to look at this on the CT scan before. Combined petrosectomy. Again, what you do once you have done the posterior petrosal, well, you move subtemporal, you peel the dura from the temporal fossa floor, and you drill this petrous apex bone, give you a line of sight through the petrous apex to look from subtemporal to the posterior fossa dura. This is cartoon from Kentaro Watanabe, who was my fellow several years ago, great surgeon. You see here this view of Kawase triangle. The way you drill is, that's the way I do it, of my drilling, the steps of the drilling. But what's important to know is that you have different corridor on Kawase triangle. You have this premeatal space, which is something you see up front. You have this drilling above the internal auditory canal, and you have this drilling between internal auditory canal and superior semicircular canal. Depending on the pathology, you may not need one or the other. The green one is drilling the true petrous apex below Meckel's cave, quite important in petroclival meningioma or some other pathology. Again, transposition of the sinus, we talked about it. Cutting the superior petrosal sinus, I try to cut it as much as anterior as possible. So I'm not really doing like this anymore, because you never know with the veins. The more veins you take out at the beginning, the less latitude or option you will have during the case. You never know what will come next. So I try to keep all the veins as much as possible, because I may need to sacrifice veins during the rest of the case. So if you keep it, it's better. Obviously, if there is no hearing, it's simpler. It's more easier. You can drill the labyrinth quite easily. It gives you more space. This is what we do now in terms of incision. We do a question mark incision behind the ear, starting at the tip. It allows less soft tissue trauma compared to the big C shape. And it's more focused on the petrous ridge. You see, it's a craniotomy like a mini pterional, both sides of the petrous ridge. And I focus more on the petrous ridge than before. Closure, Pierre-Hugues talked about it. Focus on the closure of the middle ear, but sometimes you have variations, communication between air cells of the anterior petrosectomy with the middle ear. So you have to be careful looking at the CT scan, but most important is to close the middle ear. And I close with fat now. I use many types of closure, but just fat is working very well. I show you a few cases. This was a big schwannoma it was a neurofibroma of the oculomotor nerve. So here I used only a posterior petrosal approach because this tumor was mostly retroinfundibular. I wanted to come from the back, which was better than doing a Transylvian approach, working between carotid and optic nerve during the anterior case. So here, just a posterior petrosal approach. I didn't do an anterior petrosectomy here. It was not the corridor I needed. This is here the opening of the posterior fossa dura. I guess it was to get some CSF. Yes, here is to get some CSF easily. You like this, everything become less tension. It's easier to open the dura and to manage the rest of the opening. You see the superior petrosal sinus here. I am trying to cut as anterior as possible. Sometimes you can see from below the superior petrosal vein and cut in front. It's not easy if you do just an anterior posterior petrosal. If you have an anterior petrosectomy in addition to it, it's easier to preserve vein and to cut more anteriorly. More important is to cut the dura quite far back here above the transverse sinus to be able here to really transpose the sinus. So here is a section of the sinus. I use stitches here, but sometimes it's clips, sometimes nothing. If the sinus is very weak, just with coagulation, it works. Here is the opening. I go a little bit faster. Section of the sinus. Okay. Cut the sinus, and then you cut the dent. And once you have finished the section of the dent, well, you can really transpose. You need to cut the dent if you want to transpose the sinus posteriorly. Here was a dissection of the schwannoma, resection with CUSA. The rest of the case was not so difficult. You see the fourth nerve here in front of me. The fourth, you see it, and it's already paralyzed. It's an extremely fragile nerve, so you have to be extremely careful with it. Here is 5, 7, and 8 here, and this was the schwannoma here. This is pituitary stalk, I believe. I control always the sinus at the end because in my series of petroclival combined petrosal, I have about 10% of thrombosis of the sinus, even if nothing happened. Just I think because of heat, because of this transposition, because of drilling, because of all this. This was an interesting case of a man, 35 years old, cognitive issues, confused, white gain, loss of vision, panipo, and mild DI, and this patient had this craniopharyngioma. It's going into the third ventricle. Tough to say if the ventricle is above or below. It seems to be above here, looking at the brainstem. You see that there is a little bit of edema of the optic chiasma. Yes, definitely the floor is above. And here decided to go endoscopic first. So endoscopic is very nice. If everything is easy, it's perfect. Classic endoscopic approach, cutting the sinus, getting to the lesion. This is not the purpose of this lecture, so I go fast. What I want to show you is that at some point I was into the tumor, which was extremely adherent to the hypothalamus. Patient had already some obesity, and there was some edema of the hypothalamus. So here are two options. Either you tract and your patient is much worse, or you stop here, and I decided to stop here instead of trying to tract this capsule away. So unfortunately, patient was fine post-op, but it was a papillary, but BRAF was negative. Here, post-op, you see that the tumor is growing fast, extremely fast post-op. The cyst is coming back. This was a post-op MRI, and a month after, it's like before. So this patient was admitted in emergency in my department, but I was not there. So they just did a ventriculocysternostomy to gain some time. And again, the cyst came back extremely rapidly, same. So here I decided to do a posterior petrosal approach to try to have a better control of the cyst wall on the hypothalamus. And this is what I did, this posterior petrosal approach to get to the tumor. So same than before, cutting the superior pectoral sinus, cutting the dent to get to this craniopharyngioma. I did few cases like this. Maybe I think I did 4 cases, 3 or 4, and only for big tumors like this. It's a very nice approach. You get quite close to the tumor. Little bit difficult sometimes because you have to work above the third nerve. Third nerve is in the middle of your surgical field. You have the perforators coming from the PCOM. That may be an issue also, but it's a nice control, short working distance with the craniopharyngioma. So here I empty the cyst first, which gives me some space. And then progressively I peel. You see here the perforators coming from PCOM from the tumor. It's very nice because you can really get to the surgical plane, to the good plane, which is more difficult endoscopic because you don't have the same dexterity with the endoscope. So progressively here, I got to the tumor. You see that you have those tiny vessels here around. You have to be careful with your instruments, with the CUSA. But progressively here, I peel the tumor away from the hypothalamus, or at least from something. It was quite nice of a dissection. I don't think I would have been able to do that endonasally with the previous approach. So the patient was fine post-op. He took some more weight, but not too much. And he is controlled now. It's quite a long time that I did this case, maybe 4, 5, 6 years ago. Do I have the post-op MRI? I thought I had it. Maybe it's after. Yes, there was a tiny remnant, but until now, the patient did not recur. Petroclival meningioma, this is the case for which I use a combined petrosal. That's a combination of both posterior petrosal with drilling the petrous apex also. I think we have similar techniques with Pierre-Hugues, soft tissue dissection, as I told you. This is the incision, question mark incision behind the ear, about the same L-shaped craniotomy in this case, cosmetic mastoidectomy in this case. Here, it was a time where I was still opening the middle ear a little bit too much. Now I am not opening the middle ear too much to avoid otitis media post-op. You see at the beginning that I peeled the dura away from the petrous ridge. It's really a petrous ridge approach. You need to focus on the petrous ridge. And if you peel the dura from the superior surface, posterior surface of the petrous bone, it's like you expose the sphenoid ridge and then you drill it. This was here the anterior petrosectomy, peeling the dura from V3, doing the anterior petrosectomy. I am drilling a little bit more here behind the posterior canal. You see internal auditory canal here, the corridor of the posterior petrosal and anterior petrosectomy. And this is the opening of the dura. Opening of the dura can be painful. It takes sometimes 20 minutes, sometimes it takes an hour because you need to manage the veins. And it's a big part of your exposure. In petroclival meningioma, what I do is a section of the tent with a posterior cut behind the tumor and an anterior cut starting at the porus, going more anteriorly. Like this, you take completely the dura mater out of the patient. And this is really the door that you open on the tumor. Once you have resected the dura, the tentorium, you have a very nice exposure on the meningioma. So it's something that was described, I believe, by Fukushima, and it's extremely important for petroclival. You see here the tumor around 5. You work below 5, above 5, 6 nerve is still challenging. Sometimes but it's rare. It's really going into the tumor. Most of the time it's pushed anteriorly, pushed against the clival dura. So the way I find 6 now is really to find 6 below the tumor. And I adjust the drilling according to this, because that's the best way to identify 6. I think 6 was here. That's 6 here. So 6 is really a difficult nerve to identify and to keep. And it's definitely the most frequent cranial nerve dysfunction that you have with those big tumors. So this is the end of the surgery. This is a third nerve. Third is also difficult sometimes, but it's a petroclival meningioma. Usually you have arachnoid between the tumor on third that helps with the dissection. This is third. You have contralateral third. And this, at the end, show you the beautiful view that you have with those multiple angles going from down up. You really turn around your microscope and you can look at almost every cranial nerve. This was epidermoid cyst, giant one. I will go fast on this. The video is about the same. Combined strategies. This was a complex chordoma. You see that it's going extradural, intradural. Here I did both, endoscopic for the extradural part and combined petrosal for the intradural part. The goal was to try to keep this patient intact. She was almost asymptomatic. And it was my fear, with the third nerve completely laminated here above. If you come from the nose, you suck the tumor, you have third in your section, you can have a third. And a third post-op can mean a non-functional eye forever. So here, endoscopic endonasal, one nostril. We took everything extradural out through the nose. It was not as soft as expected. Here is the hole through which the tumor is going intradurally. And I tried to stay extradural. I didn't want it to see CSF because the goal also of this strategy was to avoid CSF leakage. We identify 6 with the monitor, and this is the hole through which I feel that the tumor is going intradurally, like we say in bouton de chemise in French. And we close here with tacocil and fat. And I think I did some stitching of the mucosa, which is a technique we use now for endoscopic endonasal. So here is the intradural part. That's the approach we used. Combined petrosal. This mini combine, you see that there is quite limited soft tissue dissection. It's a goal of this mini combine. It was a young patient, so I did a one-piece L-shaped craniotomy, small craniotomy. It's a chordoma. It's easier to manage than petroclival meningioma. You don't have this infiltrated dura hyperostotic bone to manage, so it's much easier in terms of approach. Fascial nerve here. Posterior petrosectomy is done. I am moving forwards to do the anterior petrosectomy, focusing on the premeatal and suprameatal. It's tough with this angle to drill the postmeatal triangle. That's the disadvantage of coming from the back with this mini combine. Here, opening the dura above, below superior petrolaris sinus. You see here, I am cutting extremely anterior. It's not a petroclival, so the veins are working. In a petroclival, sometimes the veins are occluded, or at least the anterior aspect of the sinus is occluded, and it can include the vein. But in a tumor like this, it's better to keep the vein if you can, so to cut the sinus anterior as much as possible. I was happy to come with my dissectors, 2 hands dissection for some part of the tumor with 2 pincette technique. There was some calcification. I mean, it was more adherent to the nerve and vessels than expected. Look at the floor of the third ventricle with the 2 mammillary body. This really gives you the line of sight. And I can see the floor because I am coming from very, very far below, down, up. And it's almost like an endoscopic view on the nasal, but from the back. And this is only due to the transposition of the sinus. Closure like usual. Bad complication when you have petroclival meningioma like this with edema of the brainstem. Be extremely careful. Don't try to peel the tumor away from the brainstem. Keep a thick carpet, because having a thin carpet means that you get closer to the perforators, and be extremely concentrate until the end. Here, almost at the end of the surgery, scissors, I cut a vessel. I think it was a PICOM. Had to do the hemostasis and look at the stroke. This patient survived, but he doesn't have a good memory of me. So thank you very much, and I hope you enjoy it.
Thank you so much, Sebastian. Very nice, as usual. Pierre-Hugues and you have detailed all the aspect of this approach and its interest in some indication. I saw in the chat box that there are some discussion about the vein preservation and the sinus dominance. Is it truly a contraindication for you if the sinus is dominant on one side? And more specifically, also there was a question about the section of the superior petrosal sinus in case of dominance and in proximity of the vein of Labbé. So what is your attitude in this situation? Dominance is a contraindication?
But if it's a single sinus on one side, on almost no sinus on the other side, yes. I mean, I don't do it. I don't remember to have that I met this. I mean, I encountered this situation, but definitely I'm looking at the dominance of the sinus before, and I'm looking at the vein of Labbé. I'm looking at the superior petrosal vein. I'm looking at the superior petrosal sinus. We do an angio for petroclival, large or giant, systematically. So we have the information from the MRI, MRV, angio to look carefully at the veins, and you adjust your strategy according to it.
Pierre-Hugues, any comment?
I definitely do agree. Dominance isn't a big issue. Of course, this is a single drainage of the patient. You will be reluctant. But I'm much more concerned when I'm doing anterior petrosectomy because middle fossa veins alongside the temporal lobe, they sometimes have a big drainage. Even some of them, they drain toward the foramen ovale. And in this case, you know, particularly in the left side, elevation of the temporal lobe and damage of the veins, of course, is an issue. But I wouldn't say that for pre-sigmoid, I found any issue. Of course, depending on the connection between the vein and the sinus, you have to manage the tentorium in a different way. I do agree, of course.
Any other comment of you about the one specific aspect that you have each other covered? I would appreciate a lot of young trainees with us. What are the trajectory that you follow in order to master such techniques? I expect a lot of hours in the lab, but if to be specifically trained for such approaches, what was your personal trajectory?
Perhaps I can tell because I'm a little bit older than Sébastien, and at the beginning we learned a lot from ENT surgeons, and when your mentor is working routinely with an otologist, of course this collaboration makes you much more competent at the end to drill by yourself. You cannot try first on the patient, of course. You have to train a lot in the lab, and this is an opportunity because the petrous bone in the lab is exactly the same than in real life. That's why this anatomy is reliable, and of course you need to work in the lab and to drill a lot. Now you have 3D printers who can help you to drill in more without the dependence on the lab, and it's reliable. But working with the ENT is key at the beginning with otologist, and working in the lab by yourself then is key, of course. I would say that. But Seb has another idea.
The same, exactly the same. I think we had a similar path, Pierre-Hugues and I, a lot of lab work. Pierre-Hugues, he was with Fukushima in the US. Me, I was in Cincinnati. I mean, I spent a lot of time in the lab drilling, but for this petrous bone drilling, the mastoidectomy is not the difficult part of it. I remember when I was in the US, the ENT resident were doing some mastoidectomy at the beginning of their residency. It was really something quite simple in their training. What's difficult is the full pictures, dura, venous issues, all the tip and tricks around this mastoidectomy. And this, you learn it with experience, with mistakes, with looking at others. And yes, I just see a question about pre-op embolization. It's Anna Ferreira from Porto who asks a question. I do personally, and I don't know what's your opinion on that for petroclival, Pierre-Hugues, but we do it systematically for big ones. And I have to say that embolization can be quite helpful, not always, but for the ascending pharyngeal, for example, when it's a big feeders, if they can embolize it, coil it before, it's extremely helpful. So yes, we do it. And it gives you information also about the feeders, where the feeders are coming from, which is information for the approach, how you should tailor your approach to target the feeders. So we do it systematically for larger giant petroclival.
Yeah, that's interesting because I do
only for petroclival meningioma, not for others.
I do not do that anymore because thanks to the approach we perform, which is a transpetrosal, transtentorial, transdural, you control the feeders first, particularly the ones coming from the intracavernous portion of the carotid artery, Bernasconi, or all this. Ascending pharyngeal artery is quite challenging to embolize for the endovascular guys because they say that they can damage the nerves because of hypoxic risk with the nerves. So they are a little bit reluctant to do that in my department, but we used to do a lot. I stopped to do that because it's really exceptional that I have to give blood to the patient during surgery. Of course, it's hemorrhagic, but I stopped with that. But it's probably something which is still helpful because you soften the tumor, and it's helpful to dig inside. Perhaps yes.
I had few cases of petroclival where the main feeders was ascending pharyngeal. They use coil. They don't use particle. Particle is a mistake. If you use particle, yes, you can worsen the patient. If you use coil, the risk is, I think, is very low. Since I am here and they are using coil, we never had an issue. It can happen, but it's important. But I had cases where the tumor, when you go for surgery the day after, the tumor is completely necrosed and you suck it. So it's interesting in some cases.
Sébastien, so that you use a Doppler to check the patency of the sinus at the end of the procedure. Do you have any experience with ICG video angiography to check it?
No, I have to say I could use it, but the Doppler is more simple. But I had we look at the series of about between 50 and 60 combined petrosal, and we had 10% of thrombosis postoperatively without injury. Because if I have an injury, it happens to me once. A big injury, I stop the case usually, but it happens 10% of the time. None of the patients were symptomatic, but I don't know what you do, Pierre-Hugues. If you see it, it's always a question of giving heparin or not. It's a difficult decision. Hopefully, it's extremely rare to have a symptomatic in my practice thrombosis, but it's not unusual. That's why you have to be extremely careful with the manipulation of the sinus. If you transpose it for 5-6 hours and you have no flow into the sinus because there is too much retraction, definitely you can have a thrombosis. So that's why I check also with the Doppler once it's transposed. I mean, once it's retracted by the dura. At different stage of the surgery, I control. And you can use the Doppler also for the veins. So it's a useful tool in my practice.
Yeah, I do agree. I use the Doppler for the arteries in case of any question. For the veins, I really share your experience. Most of them, they are asymptomatic. And that's funny to find that when you are performing even regular retrosig approach, if you check the post-op, sometimes you little bit drill, you little bit expose the blue line of the sinus, no more than that. And in some cases, you have some asymptomatic thrombosis for regular retrosig approach too. Usually they are purely asymptomatic, hopefully. So I guess there is, I wouldn't go for the heparin systematically. I won't do that.
There is a question from Pedro Silva from Porto also about retrosig dural window. Do I use it? Yes, it happens sometimes in petroclival that after a combined petrosal, I also do a retrosig window to look down in the petroclival, in the clival depression. I don't know if Pierre-Hugues is also doing that, but I do it also sometimes to get some CSF rapidly, because it's a very easy way to get CSF rapidly when the brain is very tense, and to have a better control of facial nerve on the lower aspect of the tumor. It happens.
Yeah, I do agree. Exactly. I'm more confidential with the use of combined petrosectomy than you, Sebastian, you know that. And mostly I try to use the anterior petrosectomy alone. But in the case where the tumor is going at the level of the lower clivus and at the vicinity of the lower cranial nerves, it's excellent, of course, to do the combine and to go retrosig to control the lower cranial nerves from the back, which is the best corridor, without any doubt.
Any other comment, Sébastien, Pierre, Stéphane?
No, I'm very satisfied. I was impressed by the mini combine of Sebastian, but as he showed, your line of sight is very, very oblique, and you come from the back. You cannot come from below the temporal lobe, but you come underneath, and in this way you preserve the temporal lobe. I do agree, but the way you drill the petrous apex in front of the labyrinthine block is challenging, because the labyrinthine block is very bulky. And if you do not drill, by the way, the common cruise sufficiently, this is very bulky and it will hamper your vision. So your way to drill it above the pre-meatal triangle is challenging you using this mini. Can you comment that?
It is. It can be quite challenging. I agree. And but now we have those angle drill, I don't know if you tried it, where the shaft is going until the end. So this helps because you can put the drill inside and you push down and it's doing the job. But that's an option. But it's yes, it's difficult to drill the post-meatal triangle. So but for those petroclival, what you need more is this drilling below Meckel's cave, in front of the internal auditory canal. The post-meatal triangle is not very useful. So for most pathology at least. But you're right, it's a little bit more challenging because you have a more posterior line of sight to do the anterior petrosectomy. So that's why I'm not using it for every cases, but you push the limit and you get used to it. And
there is another question. Any of you had the nasal CSF leakage after this approach and how to manage it?
I had one.
And what have you do?
I had one in epidermoid cyst patient, and I closed the middle ear like I do it every time. And I didn't saw that there was a communication between the anterior petrosectomy drillings that I did directly to the area of the Eustachian tube. So I had to go back and put some fat and on bone wax on the margin of my anterior petrosectomy. Yeah, I think it's very rare because all the cases we did of anterior petrosectomy, and we just published a good number of it. I never had a CSF leakage through the nose. So this happens with a combined petrosal. I don't know, Pierre-Hugues, if you had some leakage.
I I have 3% of CSF leak from the nose for anterior petrosectomy.
3%?
3%. And I did more than 100, 150, something like I had 3%. You have to redo and to plug again your anterior petrosal bone. By the way, this is a really narrow resection of bone, but it's in close communication with the middle ear, and you have to plug back. But sometimes in big approach like combined, it's difficult to find the hole. That's why usually I systematically perform what we call a cisterno scan, and trying to find the leak, because depending on the hole, you will change your approach. You won't plug again massively all your petrosectomy, and sometimes it's better to find where it's coming from. But the cisterno scan can be helpful for that. It is helpful for that, and I focus my surgery, my redo surgery. But usually you have to redo and to plug again with fat. You sure?
Can you detail a little your cisterno scan?
Sorry?
Can you detail a little your cisterno scan?
Lumbar puncture. You inject some fluid, radio pack fluid, and then you tilt the patient, and then you see where it's coming from. Because cisterno MR, regular MR won't show that. So you need to do a myelography and then to tilt the head down. But it must be an active CSF leak. If the patient doesn't ooze very significantly, you won't find the place. So it's helpful. For example, if you are drilling a retrosig approach, if you are drilling the mastoid, if you are drilling the posterior wall of the meatus, and if you have some leak, you want to know where it comes from. Is it coming from the posterior wall of the internal auditory canal, or is it coming from the mastoid hair cells? And this allow you to focus your second look surgery. That's why I do that.
Thank you. Any other comments? Otherwise, I would like to express my thankfulness to all of you three for this wonderful seminar. It's a difficult topic, and it was very interesting to see how you master that. So thank you, Stéphane. Thank you, Sébastien and Pierre-Hugues. And it will be a pleasure to, hey, salut, you are not alone. Salut, Jason.
Okay, the anatomist. He cannot operate, he's anatomist.
C'est qui? J'ai pas vu. C'est qui?
Jason.
This is Jackson.
Salut Sébastien.
Ah, Jackson. Ça
are
va
in-
de côté?
So
Okay, guys.
I hope to see you again for the next webinar dedicated to the craniocervical junction. Normally it should be organized in October, and you will be with us.
Bye-bye. Bye-bye.
See you next time.
Thank you so much. Bye-bye.
Bye bye, guys.
Bye-bye. Bye-bye.